How nerve regenerate? The concept is about band of Buckner's formation, philopodia formation, and contact guidance. So basically, when the nerve is injured, the proximal axon undergo traumatic degeneration within the zone of injury. The zone of injury can progress proximal 1 to 2 nodes from the injury to the node of Ranvier. The cell body swells, undergo chromatolysis, a process in which niche cell granules, the basophilic granules, disperse and the cell become eosinophilic. The nucleus is displaced in the periphery. This reflects the metabolic changes, which is now not a neurotransmitter but a structural degeneration, structural generation. At that moment, a messenger RNA, lipid, actin, and tubulin and growth factors are produced. Now, there is a breakdown of axon distal to the site of injury, which starts after 48 to 96 hours. After the clearance of myelin debris, the Schwann cell proliferate and make endoneural tube proliferate on the remaining endoneural tube and create columns called band of Buckner's. The hollow tube that is formed provide a path to regeneration axon to regrow. The nerve again starts creating philopodias, and they are transmitted and goes towards these endoneural tubes by contact guidance. There are three main mechanisms by which growth of philopodia happens. Number one is neurotropism, that is proteins present in denervative muscle and Schwann cells. Then is neurotropism, affinity towards neuronal tissue, and contact guidance, that is affinity towards basal lamina of the Schwann cell and fibronectin. Nerve grows at 1 millimeter per day. This can be assessed by advancing tunnel sign. Mechanism of injury: stretch, compression, ischemia, laceration, or tumor. Regarding the treatment ladder, number one is neurolysis. Nerve is in continuity, you just release the scar tissue. Number two is primary repair. It is basically a fascicular repair or epineural repair. This is best for median ulnar and sciatic nerve using 80 monofilament nylon. Resect proximal neuroma and should be not in tension. Then you can do a nerve graft, which is defect is more than 2.5 centimeter, will require a graft. Donor site can be median lateral cutaneous nerve of the forearm, sural nerve, or saphenous nerve. The length should be 15% longer than the gap. The original nerve should still be supplying the motor end plate. Then is nerve transfer. For large defects, you can do a spinal SSD nerve transfer. Then is tendon transfer, which should be done within 1 year, and muscle neurotization. This means inserting a muscle nerve stump into affected muscle. Prognosis: general factors, age, comorbidities, smoking. Local factors: type of injury like crush wound, clean wound, delay of repair, associated vascular injury, tension of the repair, level of the injury, proximal has worse prognosis, and type of injury, motor or mixed. Mixed have worse prognosis. Both guidelines for the peripheral nerve injuries: seek specialist unit, fix bone first for appropriate, and explore the nerve. A record is noted. Urgent repair is best. If not able, just tag the nerve endings. If palsy post-op, reduce the dressing, reposition the limb. If not improving, specialist advice. Painful post-op paralysis, urgent exploration, exclude compartmental syndrome. EMG, NCS, rarely needed acutely. Seek medical advice for brachial plexus within 3 days. So this important thing is painful post-op paralysis, need urgent re-exploration. It can be nerve or a compartmental syndrome.